Hi everyone, my name is Brandon and I am currently a medical student at the University of British Columbia. Today we'll be talking about an approach to the amputated digit and briefly on digital replantation. This is the outline of this module. Let's start with a quick recap on anatomy relevant to the digits. Our thumbs are comprised of a proximal and distal phalanx. These similarly apply to our second to fifth finger with the addition of middle phalanges. These bones are connected to each other by distal or proximal interphalangeal joints, and the proximal phalanges are attached to the metacarpal bones via the metacarpal phalangeal joints. The interphalangeal and metacarpal phalangeal joints all have corresponding collateral ligaments. The flexor digitorum superficialis, known as the FDS, inserts into the middle phalanges, and the flexor digitorum profundus, FDP, inserts onto the distal phalanges. The extensor tendons, including the extensor digitorum communis, extensor indicis proprius, and the extensor digiti minimi, inserts into the dorsal surface of their respective phalanges. In terms of the neurovascular anatomy of the digits, each digit typically has two palmar digital arteries and digital nerves running in parallel, with the digital arteries located on the dorsolateral aspect of the digital nerves. There are also digital veins that are on the palmar and dorsal surfaces of the digit. It is important to note that the digital artery that is the closest to the midline of the hand within each finger is the dominant digital artery and provides a greater contribution in perfusing the finger. When the patient presents with an amputated digit, it is important to take a thorough history and physical exam that not only accounts for the injury itself, but also other factors surrounding the patient that may affect their suitability for finger replantation. Particularly, it is important to ask about mechanism and location of the injury. A severely crushed finger might not be suitable for replantation. Amputation with joint involvement may result in stiffness even after replantation. Comminuted fractures and injuries with bone loss are more difficult to fixate. Time of injury is also important to note, as fingers that have become ischemic are unlikely to revascularize. Lastly, smoking or medical conditions such as diabetes might affect the digit's ability to heal, and the patient's handedness or occupation might have implication on their replantation strategy. Some patients may also opt for a revision amputation to avoid a long operation and rehabilitation process, allowing the patient to return to work more quickly. On physical exam, once the patient's ABCs are assessed and the patient is stable, evaluate the quality of the structures at the level of the amputation. Try to avoid repeatedly manipulating the fingers or applying digital blocks for analgesia, as this may affect the stump's vasculature and subsequent ability to be repaired. When examining the amputated finger, examine for signs of severe crushing or avulsions. The arterial ribbon sign, or corkscrew sign, is when the vessel appears stretched or tortuous from the avulsion, or the red line sign, where there is a red streak along the neurovascular bundle implying distal vessel damage. Both the ribbon and the red line signs are poor prognostic signs for replantation. There are several factors we want to consider when exploring the possibility of replanting an amputated digit. These include the type of injury, such as guillotine, crush, or avulsion injuries, whether there are multiple digits involved, or whether the injury occurred bilaterally. The level of amputation is also important, as this affects the ability to successfully replant with good outcomes depending on how distal or proximal the amputation may be. The time that the finger has had its blood supply cut off is also an important consideration. Digits can typically tolerate longer ischemia times of up to 12 hours given its lack of muscles. Other considerations relate to the risk of complications of undergoing anesthesia, as well as occupational and social factors that may contribute to a digit's ability to have a good outcome after replantation. Patient factors including their past medical health, ability to tolerate long operations, and expectations regarding replantation and function are also important to consider. Here's a chart summarizing the ischemia times at room temperature for each type of tissue. As mentioned previously, given that digits lack muscles, it can tolerate ischemia times of up to 12 hours at room temperature. Some indications of digital replantation include multiple digits. In this case, even if a digit is not replantable, the least damaged amputated digit can be replanted on the most useful stump to create a digit with better function. Other replant indications include the thumb, a single digit amputation distal to FDS tendon insertion, and any other amputation in any part in a child. Relative contraindications include single-digit amputation proximal to the FDS insertion point, severely crushed, mangled, or ischemic parts, multiple level injuries, and prolonged ischemia times. Unstable patients and those with life-threatening injuries are contraindications to replantation as well. There are several things to do initially to manage a patient with an amputation. First, it is important to ensure that the patient is stable. The next step will be to prepare the amputated digit. This includes cleaning the amputated part, then wrapping it in saline moistened gauze, which is then placed in a sealed plastic bag. You can then place the sealed plastic bag in a container of water and ice at approximately 4 degrees Celsius. Make sure that the amputated part does not come directly in contact with the ice or immerse in water. By placing the amputated digit in a cold environment, you can extend the ischemia time from a maximum of 12 to 24 hours. As part of the initial management, you should also later image the patient's hand and the amputated digit, as well as other lab work required before surgery. The patient should be started on broad-spectrum IV antibiotics, and tetanus status should be assessed and prophylaxis updated if indicated. Once in the operating room, several key steps need to occur prior to the replantation or revascularization of the digit. First, the amputated part and the hand or stump should be thoroughly irrigated and all non-viable tissues debrided. Then important structures should be tagged, including firstly tendons, both flexors and extensors. These may be retracted and require additional incisions to identify them and bring them back to length. Secondly, identify and tag the digital arteries. It is also important to assess for signs of arterial injury, as loss of length or extensive damage may require vein grafting. Next, veins should be identified. And finally, digital nerves for restoration of sensation. Like the digital arteries, loss of length may require nerve grafting. Generally, the repair involves several steps. The first involves bone reduction and fixation. If the bone is severely comminuted or if there's a loss of soft tissue structures, the bone can be shortened up to 1 centimeter. This allows for better approximation and minimizes tension on the repair of the neurovascular structures. Then the tendons are repaired, followed by repair of the arteries and veins. It is common to repair the digital arteries first to address ischemia time, and it can allow the venous system to fill. If there's lost length, vein grafts can be used. It is important to repair at least 1 digital artery and 2 digital veins, as venous insufficiency is a common cause of replant failure. Once the vascular status is addressed, the digital nerves can be reapproximated. Finally, soft tissue coverage can include skin closure and possible skin grafts or local flaps. After the repair has been completed, the patient should continue to be closely monitored. When it comes to postoperative care, the patient should be placed in a comfortable and warm room, as well as staying hydrated to prevent peripheral vasospasm. It is also important to frequently monitor and assess the digit circulation status, as there is a high risk of replantation failure within the first 72 hours. Prompt identification of vascular compromise can allow for interventions that can potentially salvage the replant. This can be done through clinical exams as well as pulse oximetry. For anticoagulation, aspirin is typically given for 30 days. Any additional anticoagulation required is patient-dependent. In cases of replant with venous congestion, leaching can be used to enhance oxygenation and bleeding locally. However, it is important to give fluoroquinolone prophylaxis to prevent Aromatis hydrophilia infection. Lastly, the patient should initially be immobilized with splints after surgery. However, with the help of a hand therapist, the patient can gradually begin initiating passive range of motion and later progress to stretching at approximately 6 to 8 weeks. Early exercises can help prevent joint stiffness. This concludes our module on the amputated digit and approaches to managing it. Thank you so much for your time and attention.